Hello, everyone. I'm Lisa Gittens-Williams. I'm the Director of Obstetrics at University Hospital and a professor at Rutgers, New Jersey Medical School. Welcome to this exciting series for Maternal Health Awareness Day, and it's organized by Greater Newark Healthcare Coalition's Women's Reproductive Health Clinical Advisory Group. Our topic for today is maternal mental health, and I'm delighted to be here with our panelists. We have with us Dr. Vanessa Parisi, who's a practicing OBGYN, also a laborist, and she, in addition, is the president of the New Jersey O&G Society. She's a maternal mental health expert. And also with us, we have Lisa Tremayne, who is a survivor of a perinatal mood disorder and the director of a maternal mental health program at Robert Wood Johnson. So I'm delighted to join you to our panelists.
Thank you.
So we're going to kick it off with some questions. For Dr. Parisi, when we talk about maternal mortality, we often focus on the clinical issues like C-section rate and hemorrhage and other chronic health issues. And the contribution to maternal mental health is often neglected. But recent data shows that maternal mental health is one of the most preventable causes of maternal death. So why is this topic often overlooked?
I think that there's stigma still in the community that needs to be addressed. I think we need to consider mental health like we consider any other body system. I think that sometimes there are some pressures on clinicians as far as time constraints, and this is something that takes time. You have to develop a rapport with your patient, you have to earn their trust and invite them to share. A lot of patients would speak up if it's just addressed rather than the provider expecting the patient to bring that to the exam room. Sometimes patients can feel like they'll be judged. They may feel there'll be punitive measures for them or their child. So I think it's a forgotten topic. A lot of women, I tell them, yes, this is supposed to be the happiest moment of your life, but it isn't always, and that doesn't make you a bad mom. That makes you brave for speaking up about it. So I think that the providers, we have to remember that this is not, it's easier to come and talk about a stubbed toe or to talk about a headache or to talk about a belly ache than to talk about that they're having problems at home or they're having concerns or intrusive thoughts. And I think we really need to normalize that as providers and put that in the forefront.
Do you have any comments on that topic, Lisa?
I just was happy to be shaking my head the whole time because everything you're saying is so on target. And the key word is normalizing this very common health condition that happens to live in our brain instead of in our hearts or in another part of our body. And by talking about it more, and I like to equal it to gestational diabetes or to preeclampsia, we're all about that and diagnosing it and getting the right help. And if this happens 7 times as often, why aren't we bringing this up every visit too?
Yeah, absolutely. And I think that the providers have a role. Right. We really do need to recognize and build capacity in our workforce for providers to learn about this, educate ourselves and throughout medical school, throughout nursing training, all of our paraprofessionals, and actually the whole society, right? There's a real societal problem. So another component of this, maternal mental health is actually homicide. And the data also supports that homicide is a leading cause of maternal death. And that can also be related to domestic violence, et cetera, and stress, chronic stress in the household. So how do you pick up that? And this is really specifically for you, Lisa, since you're, with the moms on the ground. How do you interface those concerns?
We've become very good at making uncomfortable subjects comfortable. I feel, in treating and seeing over 50 women a day, being able to ask about intrusive thoughts, like Vanessa said, and safety at home, and are there guns at home? Patients are in law enforcement. We have patients in nursing. We have teachers, and making it as common as, do you have a thyroid disorder? Is there a gun in the house? Have you been having any thoughts that have been scaring telling you lately, you're in a safe space. You know, this happens to so many women, and everything can be fixed as long as you share with me what's going on. We have a really good turnout of people telling us really, you know, scary things and trusting us.
Yeah, I think asking those specific questions. And so I don't know that providers always have that script. Dr. Parisi, you've been involved in actually training as a maternal mental health expert and as well as for prescribing. You know, what's the script that providers should be asking? And does that script go beyond asking the questions in the postpartum depression screen?
Sure. I think that it starts from when the patient walks into your office. I mean, the mannerisms, their comfort level with an exam, how their partner acts in the room, if they're, you know, if the partner's answering for them. And sometimes it's just because they're overexcited, and other times there's a real control issue, or maybe there is an intimate partner violence going on. I think it's just watching the nonverbal cues as well, how a patient approaches a speculum exam. I've had a patient who had to sing through her speculum exam, and I knew something was up immediately. So I knew what to expect. I prepped my staff without sharing too many details, but I didn't want them to have any nonverbal cues themselves that were reactionary to the patient. And just kind of setting the scene, and like Lisa said, making it a safe space. You want them to feel that they can open up to you. I personally, you know, I had great training. But the one area I feel like I always lacked was with perinatal mental health. You know, we got okay, you do the EPDS and then what? So I have had friends, family members, patients. I was in solo practice for several years before I came into the hospitalist role, and that have gone through perinatal mood and anxiety disorders that have gone untreated, whether they were nervous to speak up or their provider never asked. And I just didn't know how to address it. And where I was originally, we had one psychiatrist that we could, and it was such a populated area, but we had one psychiatrist that everybody referred to. Well, that person is going to become inundated very quickly. So I said, let me, you know, get involved. I just did a search. I found Postpartum Support International. I was like, what is this PMHC, which is a perinatal mental health certification that licensed providers, their nurses, OBGYNs, behavioral health specialists who take this extra course. You do it where you do a 2-day course. There's certain requirements. So a 2-day general course. And then if you're a non-behavioral health provider, you can take advanced psychopharmacology. So at least for those first couple of weeks while we were trying to get a patient into a provider, if they didn't show signs earlier, I could prescribe them medication. I could give them the care that they need to bridge the gap until they could get to somebody more qualified than me. So it's really helped me tremendously. Wendy Davis and the whole crew, like everybody is amazing. It's a really large network. It's international, but you hear the same names coming up. And
I think that providers really can know that they can go to the website for Postpartum Support International, and patients as well. They have like a dearth of material available. So I'm glad that, you know, that's really such a resource. But I do want to focus back on like picking up these moms' feelings. And some new literature suggests that, for example, for Black women, they may not manifest signs of depression that are similar to other populations. They may be less likely to reveal that, in fact, they're having a problem. And some literature supports that they might manifest more anxiety. So how do we pick up, Lisa, this is really for you, how do we pick up those other signs of depression or other signs of perinatal mood disorder that are outside of the realm of typical depression symptoms? How do we identify those moms?
Yeah, you're probably so sick of hearing me say this, but it's such an exciting opportunity to be involved in this week and to have ACOG support for the year talking about maternal mental health. It's named wrong. And if it's named wrong, then no one knows what they're looking for. If gestational diabetes was called gout, we wouldn't have half the phone calls. So if we're calling it postpartum depression, you know, and you've watched any TV show, depression is crying and not being able to get out of bed and maybe not taking care of myself and my hygiene. But what moms are feeling is overwhelm and panic and racing thoughts and this inability to feel like they're a good mom, and it's all based in anxiety. And then add in being a woman not from this country, a woman of color, a woman of different religious and all those expectations. It's no wonder if we don't have clinicians who are trained coming from all over the world and all the different populations, how are we going to treat everybody? It really goes back to training residents, nurses, other social workers to feel it and see it and know what to do with it.
I really love what you're saying about the other signs of maternal perinatal mood disorders, right? It's really not just depression, but that seems to be what is the focus. And it has to be very clear that when you have anxiety disorder and you're trying to be a mom and take care of a new baby and take care of yourself and recover from your cesarean section and maybe get back to work, there's a lot on your plate, right?
Yep.
So moms really do have a lot on their plate just being a mom. And when you add on top of this, these mood disorders, it really can be overwhelming. But I love what you're saying, and you're right. We really need to change the way we talk about it and the way we educate about it. But we also need to figure out how we're looking for those, how are we looking for those signs and asking the patient about that. But when you're looking, what is it that you're looking for?
I like to use
Dr. Parisi, you can answer
Vanessa,
that.
I'm horrible. You go first.
No, you're totally. So I try to normalize it, and I tell all the patients before they leave the hospital, 80% of women get postpartum blues. This is going to happen more times than not. Your hormones are shifting. This is very normal. You're not sleeping. You have pressure from the in-laws. You have a lot going on. Let us know what you need. And I look at the partners too, so they know that it's normal, that it's not just being crazy or just being hormonal. I hate those things. It's really, this is a physiologic change in your body, and you can't help how you're going to respond to things. So you take, I said, we worry about the three of you here. We worry about the partner, the baby, the mom, and we, need to just normalize that. I tell them there's support groups. There are people who are going through the same things that you're going through. There is the Maternal Mental Health Hotline, which is a 24/7 hotline. I used to do counseling for them when we first started. And I give these resources because I said there's a lot of information coming at you. It's going to be in your discharge packets. And I think the biggest thing is asking who your support system is. You have to divide in these pressures, like who in your life is helping you and who is being a detriment. So if your mother-in-law is coming, and no offense to mother-in-laws, but if they're coming and saying, well, I breastfed without an issue and I was so happy and I don't believe in therapy, it's going to put added pressure, and it's going to make mom go into her shell. And I feel like it's really, really important that we just find out who the support people are, who's going to go. And I say, listen, if mom wants to clean your kitchen, let her do it. Your job is not to entertain. If, your neighbor wants to come help walk your dog, let them do that. It's all about you just getting what you need at this point, sleeping when the baby sleeps, and you speaking up if you need help, because that's what we're here for.
So you're talking about the postpartum period in the hospital, but when should we really start talking about this when the patient's coming for prenatal care? When do you have this conversation that there is such a thing as a perinatal mood disorder, and that it might exacerbate itself in the postpartum period? And I speak about the postpartum period specifically because the mortality for mental health in the postpartum period is 42 to 365 days. That's the highest rate. That's when the patient's not even necessarily seeing their OBGYN doctor or their midwife or their APN or whoever has been rendering them prenatal care.
I try to approach it even at the annual visit, and I ask people what their plans are for the future, what their fertility plans are. And I say, when you're thinking about conceiving, come to me 2-3 months before. Let's have a talk. Let's get you on a prenatal vitamin. Let's talk about what medications you're on. And I do address any sort of baseline depression or anxiety, because then we could have a 20-minute conversation of what we can do to prepare them. And then if they didn't have that and they become pregnant, then at the confirmation of pregnancy, I think, and I learned that the hard way, because I didn't always bring it up at the first visit. And then I realized postpartum, a patient, went through a really tough course, and she's like, well, this happened with my first one. And I realized that I had missed that as a provider. So you learn from your mistakes too, Whereas like, I need to be bringing this up. The patient's not always going to be bringing it up because they may be worried about stigma. They may be hopeful that it won't happen again. So they might be denying it a little bit. But I think bringing it up at the beginning and then multiple times throughout the antenatal course is really important.
I really like that. And I especially like bringing it up in that preconception visit. There's so many women that are delaying pregnancy or delaying childbirth because of their career. They're thinking about freezing their eggs. They're not really clear what their reproductive plans are. But as they consult with a provider, this should be really a question that's on the list, just like we're asking about diabetes and hypertension, and as well, family history of mood disorder, right? That's also very, very important. We really need to know what's their experience, what their experience has been, and what their family history is. And I also like the support person concept. I think it's really important. I know that in my practice, I always ask who is going to be your support person in the labor room. But I think a further question is who's going to be your support person after you deliver, because that can change. Sometimes a partner has to go back to work. Sometimes a mother has to also go back to work, and we need to make sure that, you know, patients are supported. I can personally remember being home with the baby thinking everyone's gone. Now it's just me and this baby in the dead of winter. So yeah, patients, we really need to know who their support person really is. Some of these programs that support and foster the emotional well-birth of new parents are available, but you know, patients don't know about them. And so, and at the discharge from the hospital, there's just so much information. There's post-birth warning signs and keeping track of your blood pressure. And mothers are really focused on the baby. Does the baby have a high bilirubin? And do they need to get their hearing rechecked? And did they get all their shots? It's really overwhelming. How can we let parents and families know about the services that are available? We have so many relationships with organizations like Postpartum Support International, Greater Newark Healthcare Coalition, the Partnership for Maternal Child Health, and all the other organizations, great organizations here in New Jersey. How do we connect those people, those community resources to our patients?
Wouldn't it be a great service if we could reach out to every mom somehow who gave birth or had a loss, because those same hormones are at play, and nobody wants to talk to a mom who lost a baby as well. Reach out via a text program and let them know that we want to know how their emotional health and well-being is doing as much as they're doing physically, that they could respond back and we could give them something. A support group, a team member, a 1-800 number, a PSI group, an online group, something. Women feel so validated with that baby step of you hearing what they're saying. So there's got to be in technology today a way that every hospital who has a baby to reach out and say, after the 2 weeks, like you're saying, right? Everyone's gone. How are you? Not your baby. How are you?
Yeah, I really like that. This morning on the news, they were talking about the artificial intelligence that can take college courses and actually get better grades than some students, and how it's dangerous. It may become dangerous, but you know, if such intelligence exists, why can't we have something where we're reaching out to all moms?
Yep.
New Jersey is at the forefront, and now we have a visiting nurse service now, being able to go out to homes. But I think, you know, directly connecting with those moms and giving them that space to say yes or no, or have that information is very, very important. So for Maternal Health Awareness Day, since we are recognizing maternal perinatal mood disorders, the Maternal Mental Health Hotline does have a little card. It's like a wallet card. You can put it in your wallet, and it has the phone number for the hotline, which is 1-8339 HELP for moms. And so I think just being able to connect to people could be really important. And I think this hotline is going to be game changing. What are your thoughts on the hotline?
So I actually did, when I was with the launch of the hotline, and it was amazing. I mean, you have the text capability. And I think the texts were nice because we could send the PSI directory with a way to find a provider. We could help people really get through the night, because I had birth parents call, I had partners call, I had mothers call, I had a lot of people call, and I always took the night shifts. So it was like, I'm going to see my doctor in the morning, but I just need to talk to somebody. And there's all that mom guilt, and I don't want to wake my partner, or they have to work tomorrow. I just need to get through the night. So we could give them resources. It's not a counseling hotline. You can give tips, but it's mainly a resource hotline and a support hotline. So if there is a call that we believe need to be escalated, then it would be moved to another hotline. However, it's just nice to have someone always there. So texting or calling was a great opportunity, and it's staffed by such supportive people. So I really urge anybody to reach out. And then there's different support groups, there's different resources that you can find out that are in your local community. They can even go down to what insurance you have, or if you need to pay on a sliding scale. That's definitely something that I think is helpful. We'd even have providers call in and say, I have a patient that I just don't know how to get help. What can I do? And I think that was great.
So I think the hotline is really going to be great. And what's exciting about it is that in addition to being in English and in Spanish, it's translated into 70 languages. So really anyone can call and actually call that hotline and get help. So for me, we started out handing out this card about the Maternal Mental Health Hotline for Maternal Health Awareness Day. But as I'm handing it out to someone who looks well, doesn't feel unwell, I have to have like my narrative beforehand explaining why I'm giving you this, because you might not need it now, but you might need it later. What's your recommendation for what that preamble should be?
Exactly what you said. I think that just again, right back to old normalization, like I'm giving you this card because we have found, that 1 out of 5 moms, once they're home and they're alone and they have a baby, lack of sleep, your hormones and all this monotony of taking care of the baby and mom falling to the side, sometimes you don't feel like yourself. So if you need to talk to someone, here's a start.
Absolutely. And I screen my patients in the hospital, but I know that that's very limited. I would screen them at their first prenatal visit, and we know about the 4th trimester, we want to see patients multiple times. So I would see them at 1 to 2 weeks, at 6 weeks, and then at 3 months for their annual. And I would ask them, how are things going? And the question I always found particularly useful was, what did you enjoy doing before the baby was here? And a lot of moms will say, I don't remember. Like they're actively like racking their brain to figure out what they like to do. They're concentrating on making breast milk and feeding the baby and cleaning the house and taking care of their partner and not bothering anybody too much that with their problems. That, one patient said, well, I love old lady crafts. And I said, well, you were going to Michael's on your way home and you go pick up something to make a wreath, and I'm not endorsing Michael's, just but I think getting people to reset their brains and realize like there was a life before the baby, trying to give yourself 20 minutes of the day to take a hot shower or color in a coloring book or make a wreath or do something is not making you a bad parent. It's making you a better parent because you can step away from it for a second, re-energize, figure out why you did this in the first place, and realize like it's not something to be thought of negatively. You need to do things that make you a human too. If it's calling your friend on the phone or grabbing lunch with somebody, going out with your spouse for a date night as the baby gets older, these things are really important. And I think sometimes patients need us as providers to say that to them. And again, normalize it.
Yeah, I think just giving them permission. Although I will say that the sweater that I started making, the brown sweater for my son, still sitting in the closet, and he is 17. So I didn't do so well on that one. And so speaking to that, there are many layers. We talked about, counseling, and we talked about treatment and medication. Can you just walk us through what are these levels of intervention, right? So you can have meditation and yoga, and we can go all the way up to someone requiring medication or maybe even needing hospitalization to get better. So can you just talk about that as our last question and topic?
Yeah, I mean, we had to admit 2 moms this week, one who was 7 months postpartum and said to me, I'm exhausted. because I said, you sound so good. Tell me what's going on. And the more she opened the door, the more terrifying it was, quite truthfully, in that she had hung in there for 7 months. I said, what you said, what a warrior. Like, how amazing are you? What other mom does this for all these months and days? And to finally say, I need help. And she is coming in here tomorrow. Now she'll be an outpatient and she will get individual therapy and group therapy. And we will have someone monitor her medication, and she'll be in support groups and maternal journal, and all those pieces will come together to take away that feeling that they already had and confirming that they were bad moms. And every level should be available for anyone to come in, you know.
So there's
people-
journaling, and there's support groups, and
Yeah.
then there's medication, and then there's inpatient therapy.
Mhm.
And then what types of things can be implemented as an outpatient?
We do mother baby bonding, so a class in mommy music, just to facilitate mom can see the baby is feeling good. You know, that what she's doing is mattering, where she's always having such self-negative talk. We talk all about sleep, the importance of sleep as important as nutrition and exercise. We do different groups based on anxiety and coping mechanisms and panic and ways to ground ourselves. So real tools for the toolkit, no matter, again, where they're falling in this at this particular time.
And I think
Yeah, I think it's really exciting that there are all of these resources available. And so I'm going to close now, but I do thank you both for joining us and having this great conversation about maternal mental health. You're absolutely right. Your comments are on point. That we need to normalize it, and we need to continue to talk about it, and we need to save mothers' lives, and we need to get mothers back with their babies and enjoying their families, and just creating the great experience of motherhood that they wanted to have. That's why they had these children.
Yeah.
So I remind everyone to first of all that there's the Maternal Mental Health Hotline, 1-833-HELP for Moms. And I remind the audience to tune in tomorrow. There's going to be a discussion about how loved ones and partners can support new moms. So shout maternal mental health out on social media, Maternal Health Awareness Day, and Greater Newark Healthcare. Shout us all out on social media, and thank you for joining.
Thank you.
Thank you.